Well, good afternoon, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name's Jason Belton. I'm the Director of Emergency Preparedness for CAF. And today is February 5th, 2021. It's 1 o'clock in the afternoon. And for our topics this week, we're going to talk about the AFL that came out earlier this week. We'll talk about visits and testing as it relates to both we'll kind of revisit the requirements now that the community level surge is subsiding just slightly. It will allow us the ability to kind of revisit that. So I want to, connect you with the resources to be able to see when you should be offering indoor visits and what the cadence is for your testing. So we'll cover that. We'll talk about Cal OSHA. Cal OSHA has some annual requirements, and then there's emergency regulations from Cal OSHA. I just want to reinforce what portion of this applies to you and what portion you're exempt from. So we'll talk about that. And then we have a vaccine update and some information for folks in Los Angeles County as well. So, and as always, caf.org/resources/coronavirus will get you to the CAF's main website that collects all the coronavirus information. We also have a vaccine website that has information specific to the vaccine. And you can get to it from that website. It'll be the first link, I believe. All right, let's hop into our normal preamble. Just like I always say, the speaker's opinions expressed are their own. They may not reflect CAF's official position. This is a grant-funded program paid for through grants through the California Department of Public Health and Los Angeles County Health Services Agency. I have no financial conflicts. I'm employed by CAF. Intent of the webinars is to give you a situational report, bring up your situational awareness if there's anything that happened during the current week. We'll recap that. We'll talk about forecasting and best practices where we can identify those. We do have one handout as well, and it's just the slides today. So I didn't include any of the other handouts, but there's lots of links in this presentation as to where to find specific information I'm going to refer to. So I'm limited in 4 handouts, and there's really a bunch that kind of go with this as we work through this AFL. So I'll point out where those links are in a second here. All right. So in terms of the AFL that came out this week, AFL 21-08 reinforces new guidance on quarantine for healthcare personnel that have been exposed to COVID. The CDC posted options to reduce that quarantine time, and that is that link, that very first link in blue there. And then it also updated its guidance on strategies for mitigating healthcare personnel staff shortages, and both of those are linked and they're separate documents on there as well. The real, kind of crux of this AFL is that, most of the other stuff is going to stay standard, but during the critical staffing shortages, exposed asymptomatic healthcare personnel may return to work after day 7 from the date of last exposure if they received a negative PCR test from a specimen collected after day 5. So day 5 after their last exposure, you take a PCR test. If they're negative, they could be cleared to return to work. Now, the reason why I put 3 giant asterisks in front of that is that is the baseline, and that's what CDC and CDPH are recommending. Your local health department may differ from this, so it's important to understand that they could potentially say, well, we want you to stick with the 14 days and stay with that. This gives us a little bit of language to get those folks back in the buildings. And there is a risk assessment that CDC wants you to go through to be able to determine what is considered an exposure. And that is that third link there, or the 4th bullet point, sorry, and where it says the risk assessment for healthcare professionals. And then the link to the AFL is right on the bottom there. And of course, if you have questions, generally Patty does the regulatory stuff, but in this instance, if you have questions about the risk assessment or strategies to mitigate healthcare personnel, I would be your contact. So just reach out to me, jbelden@caf.org, if you have questions about this one. All right, so in terms of the other AFLs, I want to remind folks that, you know, CDPH and really wants to encourage or requires indoor in-room visitation once you have hit a certain metric or your county has met a certain metric. And so now we did a really full presentation on this AFL 2022.5 as well as the QSO 20-39 from CMS. So we did a real big breakdown, and I don't want to put you guys through that because I know some of you guys have listened to that and you understand this well, but I just want to reinforce that if you had paused, and I think most of you guys have paused because you're in the purple counties, but once you go back into one of those other color tiers, then we need to toggle back in that ability to have indoor in-room visitation, group dining, and group activities. Those are all included in that. And then where do you go to find the the county color tier? In that AFL, there's like a link to go to the CDPH website for a safer economy. That link in the AFL is actually broken, or if it is, it does not work for me. So on the next slide, I'll show you the website that I think you guys should go to be able to view this. And CDPH has told us the Safer Economy website it is okay to use that because it has a better graphical interface and we can identify the information immediately on that website. So it's going to be tied to your color category, red, orange, or yellow. If you're in one of those three categories, you're going to be able to allow indoor in-room visitation, group dining, and group activities for those in the green cohort category. You're still going to have to follow all the same infection prevention and infection control requirements, those quote unquote core principles that CMS had identified and put into the original QSO. You still have to follow all of that stuff. Nothing has really changed in terms of that. And you'll need to have 2 sequential negative rounds of response testing over 14 days among residents if you're in an outbreak. And that's important to note. There's a distinction there. It's not 2 sequential negative rounds of response testing for both residents and staff. It's just among residents. And that's if you're in an outbreak. If you're not in an outbreak, then and your county color tiers or trends into red, orange, or yellow, then you can start. And if you want a real detailed description of these AFLs, like I said, there's quite a bit that goes into the considerations around indoor and in-room visitation, group dining, group activities, things about how that can be done safely. I will say that there's been a lot of conversations, even more on the statewide calls to talk about airborne disease transmission and Cal OSHA's increased, response in the buildings. And, are there, methods that we can use, temporary methods that we can use that would increase our infection prevention and infection control in our buildings? And the response to that, especially as it relates around HEPA filtration or portable HEPA filtration devices, those devices have been shown to filter out SARS-CoV-2, but when you set one of those devices in a room, it's not cleaning the entire room air. It's just cleaning a portion of the room air. So if there is, let's say you set up one of these in your group activities area or your group dining rooms, we can't guarantee that the air that gets filtered through there is the air that is potentially contagious. So we can't say for sure that the HEPA filter will work flawlessly. What we can say is that it will increase the number of air changes per hour in a given room that you place it in. And really, without, you know, making major changes to your built environment, you have to look at these temporary methods. And if you cannot max out, or even if you maxed out all the fresh air you can get into your ventilation systems, it still may not be enough air changes per hour to really clear that space out. And I could give you a number of examples of airborne transmission happening within indoor spaces that have limited or no ventilation or have recirculated ventilation. I mean, it's at the crux of many of the outbreaks that we have seen, especially early on in the response. It's responsible for outbreaks that have happened in other parts of society. You take restaurants and food establishments and coffee houses and you name it. The evidence is pretty clear that this transmits primarily through airborne means and primarily through asymptomatic or pre-symptomatic people. And that means you just can't see where it's going to be. And so when we look at these, when they talk about increasing the ventilation, we just need to get more air through that so that the potentially infectious particles within the air are diluted to the point that they're not causing outbreaks in facilities. And I really, I know the folks at CDPH have really kind of been flummoxed that there continues to be outbreaks. But I tell you, it's not a question of if one of your healthcare workers comes in the door and they exhibit no external symptoms and they don't feel poor, the opportunity, if they have it, to spread it to other staff or other residents is pretty great, even if they have all of the environmental and in all the barriers that we've done. There's no perfect solution, and I tried to explain that to them. It's not possible if folks are only wearing surgical masks to stop that. They would literally need to wear something that protected us completely, like an N95. They're not going to request, say that everybody should wear an N95 mask. That's not going to happen. But in order to stop airborne transmission, really, that's probably the only way you can knock it out, unless you stop it at the door. And they're not requesting testing at the door now. That may come later, but certainly if we're not testing folks at the door, we're really limited in being able to identify those cases. So when we set up those materials, whether it be a MER filter in our HVAC system, or whether it's a HEPA filtration device that you set in the room, these are limited in what they can do. The real goal is we want to get as much fresh air through these spaces and keep that continuously. And I know your maintenance staff are going to go, hey, your energy bill is going to go through the roof because you're pumping in fresh air and then you're also trying to warm it or cool it. And that fresh air is not helping any. So your energy bills are probably going to go up as a result of that, but it's definitely, it really is best practice. And I think it will help, kind of minimize the size of those outbreaks in the facilities. And if you're interested in revisiting the AFL, it's linked on the bottom there. And like I said, if you want to go back and watch the entire presentation on, how we do indoor visitation and what are the safe spaces, it's linked there. You don't have to log in or anything. You can just watch it, skip to the part where we talk about this AFL. All right, so I want to jump to the next AFL as a reminder. This is AFL 20-53.3, along with the CMS QSO 20-38. This is the testing AFL and the testing QSO from CMS. The cadence for your testing is dictated by the county positivity rate. Now, I realize that CMS has a baseline of every other week for those counties that fall below 5%. But in California, CDPH has said we want and require everybody to do weekly even if you're below the 5%. So anybody on the Safer Economy website that's below 10% can convert to weekly testing. Those of you that are still in counties above 10% county positivity rate need to continue to test twice weekly. And where you want to go to check both of these, both the color tier, so remember for the visiting, it's different. It's not tied to a positivity rate, it's tied to the color tier. And for the testing, it's tied to a specific positivity rate. And so if you click on that Safer Economy and you scroll down about halfway down, there's going to be a map of California with each county highlighted. As you hover your mouse over the county and you click on it, it should give you the most recent county positivity rate. And that's the rate in which you want to determine your testing cadence. In terms of where this documentation exists, obviously the CMS and the CDPH, AFL and QSO are linked on the bottom. As we go forward with the testing, we have heard from certain counties that have supplemented or assisted facilities in their testing responsibilities are likely to pull back those resources. I know that's going to happen in Sacramento, and there's a possibility that some of these counties may integrate with the state lab, but we don't know that for sure. So I can't encourage you enough to be confident in your use of the point of care devices. We're really going to push the state to move away from PCR testing once we have high enough vaccination rates. So I really want to encourage you guys to get familiar with those devices, even if you're not using them now. All right, so I want to talk about a couple of reminders from Cal OSHA. This is, most of you guys, this is other duties as assigned, workplace safety and things like that. But every year, Cal OSHA requires every employer in the state to post their 2020 annual summary of work-related injuries and illnesses. And there's a specific form in which you need to document it on and post it. And that form is called the 300A form. So there's two forms for recording illnesses. And there's a distinction between recording work-related injuries and illnesses and reporting. So they're two different things. This is for recording. And so this is where we're going to record all work-related injuries and illnesses on that form 300. If you don't have a copy of that form, one's available on our website, or you can just click that link there that says record keeping overview, and it has a list of the forms that you need to fill out annually. So there's a form 300, which is for your records, and then there's a form 300A, which just logs each injury, and that needs to be posted in a visible area for all employees to be able to view from February 1st through April 30th every year. So this is every year that you post this 300A form. This year, because of COVID, you may have a really lengthy list, whereas before, knock on wood, you would not have any, or a really moderate amount of folks on your 300A form. So a lot of questions about, well what if COVID-19, if somebody catches COVID-19, can that be counted? Do we need to record that, or what's the delineation between whether we have to report this or not? So if it's work related, meaning the employee contracted COVID through work, in other words, their exposure was at work, then that case meets, and the case meets one of these criteria, it must be recorded on that form. So if somebody dies, it needs to be recorded on that form, and we have a few of those, sadly. Days away from work due to illness and not mandatory quarantine. So if you have an employee that is exposed, sent home, tested, and they test negative, those days away from work are due to quarantine and not illness. But if they test positive for COVID and they're ill, then you would probably want to indicate that on your 300A form. Did they require any medical treatment? Did they suffer a loss of consciousness? Did they suffer a significant injury or illness diagnosed by a physician or other licensed healthcare professional? So it's a pretty broad area in which they want you to record these things. Now, there's also a requirement for reporting, and the requirement for reporting is within 8 hours of the injury. And those things for reporting deal with more serious injuries and death. So in this case, death would not only be recorded here, but it would have to be reported within 8 hours to the Cal OSHA office, your local office. There are other things that you have to report to: hospitalization for more than 24 hours, or really any inpatient hospitalization as a result of a workplace injury needs to be reported. Now, we've done a number, we actually had a couple of attorneys come on and do a webinar earlier last year about Cal OSHA and both the record keeping and reporting processes. We also had a class that's available, I think still in the CAF Learning Management Center, that those two attorneys did. A fantastic presentation. If you've not listened to that, I suggest at least taking a look at that and verifying that you're comfortable with the record keeping and reporting requirements with Cal OSHA. And in terms of the updates where they post this stuff, I mean, I think it would probably be good practice for you guys to get on their listserv, at least until the end of this coronavirus response, because they've been sending these new and emergency stuff out at a pretty rapid pace. Not like the AFLs from CDPH, but there have been new news that definitely impacts your operation. So I would get signed up on their listserv just so I could see what they're sending out, so we don't get caught by surprise. All right, and then this is another reminder that that emergency standard that Cal OSHA put into effect January 1 of this year, it does apply to some of the employees in our building. Really, the occupational exposure determines whether there's applicability for your staff within these emergency standards. And if you're not familiar with the emergency standards, it's really kind of like there's like 5 steps within the emergency standards, and it's pretty lengthy. Most of the stuff, as you look at it, is contained within our mitigation plan. So in terms of working to create an all new plan in order to meet this, I don't think you have to do that. I think what I would do is I would review this, that very first link there that says the coronavirus ETS, that has a link, and there's some FAQs for that as well. And it brings down the 5 categories in which you do it. It's, you know, you got to have a plan for COVID prevention. That's what they call it, a COVID prevention plan. But when you look at the elements that they require in that COVID prevention plan, it looks almost lockstep in with the requirements, some of the requirements within your mitigation plan. So, you know, things like screening at the door, taking temperatures, logging visitors, you know, things like that. All that stuff, really you're already doing. What you may need to do is, you know, take that term mitigation off of it and put, have two different documents, one for CDPH and one for Cal OSHA. And on the Cal OSHA one, I would call it, you know, the COVID-19 emergency, you know, kind of mitigation plan. And, you know, just so you get away from, I don't want a surveyor coming into from Cal OSHA coming into your building and say, well, this says mitigation plan. Why does it not say COVID prevention plan? So even though it contains the same things, sometimes those folks are, there's not a lot of, you know, they don't see things broadly. Let's just put it that way, and don't see that the actions are the same. We just call it something different in our space. So be cognizant of that. For any of your staff that have occupational exposure to airborne transmittable diseases, those folks are covered under your model respiratory protection program. So I want you to think about it in terms of the people that you fit test, and they're required to wear a respirator in the course of their duties. Those are the folks that have occupational exposure to airborne viruses, and they're covered under your model respiratory protection program. For those of folks that you've not gone through that fit testing process, if they're not written into your model respiratory protection program, then they would fall under the Cal OSHA emergency standards. So we've sent out a number of posts on this. We put articles into the CAF News. I know it's a really dense, complex thing. I'm not sure I have a ton of expertise in this, but I'm not an attorney with, that specializes in Cal OSHA stuff, but I can at least look at the emergency standards to look at your plan to see if it meets the needs of that. So if you want some kind of review of what you put together, by all means, my email address is jbelden@caf.org. I get lots of emails. I will try to get back to you as soon as possible. But if you're interested to see if what you have put together complies with the rule, if you send it over to me, I will ask a couple of attorneys to take a look at it to see if we're getting it right. I have a really, I think, well-founded fear of the exposure risks that you guys have in your facilities based on stuff that has happened over the last year. And we've gotten, there was an article in the San Jose Mercury News today about somebody being fined $60,000, a skilled nursing facility in Fremont. And so these folks there's not a lot of give with Cal OSHA. And so I want you to take this seriously in terms of the financial impact on your operations, your long-term operations. These folks are not to be joked with, and even the appeal process is laborious and will cost you money in attorney fees to fight this on the back end. And so if we can cross our T's and dot our I's before it gets to that point, we want to do that. I know there's been a ton of conversations about the use of PAPRs and elastomeric respirators and what Cal OSHA recommends. The CDC only recommends those types of precautions really when we're doing aerosol generating procedures. And we don't do a ton of those in skilled nursing, but for folks that have CPAP devices, there is a recommendation to not just Cal OSHA, but CDC, American Society for Healthcare Engineers. There's a group, there's a broad consensus that says that in those instances, for people that are either they're exposed, meaning you're treating them like they're positive, or they actually are positive, for those AGPs, you should have them in negative pressure isolation. And we can't send folks to the hospital right now, but you may have the ability to set up a temporary negative pressure isolation. And I passed out a couple of guidance documents about how to develop those. I really think this might be a touch point and a look back if Cal OSHA comes to your facility somewhere down the line. And so as a result of that, for worker safety, I would strongly encourage, trying to find a way to do that if you have anybody getting aerosol generating procedures. I'm not a physician, so I can't argue the merits of whether a CPAP is really an AGP or whether a BiPAP is, or any other procedure. I can't tell you that. I can tell you almost unequivocally that I know that airborne transmission of this virus is very real. It's not even that difficult. I probably don't even have to convince you because you've seen it in your building. So just know that Cal OSHA does not play around. they're much more difficult to deal with on the back end once we've been cited. There is no reasonable method for appeal. So we just want to cross our T's and dot our I's. I hate to scare you guys, I really do, but pay attention to this one. This one's super important. And I know I've mentioned, kind of resources for learning, how COVID spreads through the air, especially if you're not an infection preventionist, or maybe you're new to infection prevention and you want something a little more conversational to discuss how this impacts the airflow within our buildings and things like that for your physical plant staff. I really think that, there's an opportunity there to engage them, to utilize their expertise in understanding the airflow and airflow management within the building. I'm going to give you guys a really helpful webinar that I watched on YouTube. It has nothing to do with healthcare at all. It has to do with coffee and creating safe spaces for coffee houses. And when you look at a coffee house, it looks very similar to an indoor environment that we would have in our dining room or something like that. It would be, or activity room, where folks would stay for an extended period of time in an enclosed environment with minimal airflow. And it talked about the impacts of outbreaks in cafes and other parts of the world, and they talked about how the air moves across this. In any case, the Specialty Coffee Brewers Association, I think that's what it is, there's a gentleman named Professor Bill Ristenpart at UC Davis. He's a chemical engineer that deals with complex transport phenomenon, which is essentially how aerosols move through the building. So if you're interested and looking at this, Jamie, can I share my screen so folks can take a look at this? I just want to show them that link because I didn't build it into the slide, but it's
no problem.
Really
let me go ahead and give you permission.
Okay.
All right, perfect, and we can see.
Okay. All right, guys. So the title of this thing is The Science of COVID-19 Safety for Coffee Businesses. And please don't let this throw you off. It's a very layperson's perspective about how aerosols work, and it will give your staff a great idea of what that means. They'll talk about like barriers and how effective the barriers are and what the limitations are to those. So I highly recommend it. It's called The Science of COVID-19 Safety for Coffee Businesses. Like I said, please forgive that it has nothing to do with healthcare, but it does talk about indoor air. And from a layperson's perspective, without killing your staff with engineering talk, anemometers and all kinds of other things, to gauge airflow, this will get them in the door to start thinking about where the exposure risks are within their facility. So, all right, can we go back now, Jamie? You go back to your screen.
Sure.
I don't know how to. Oh, stop sharing.
Let me show my screen. All right.
All right, perfect. Thank you. Appreciate that.
Mm-hmm.
All right, so as for the Los Angeles County vaccine update, second doses, I've probably gotten, I don't know, 30 or 40 emails about, when am I going to get my second dose? I talked to Dr. Gounder yesterday afternoon, and he assured us that the second doses will get shipped to your facility, but it's going to be based on the data you entered for the first dose. So whereas for the first dose, they sent out, enough and then some. And so you had overage. Their plan is not to send you the same amount in the second dose. The second dose will be based on whatever doses you entered into the CARE or CalVax So based on whatever you entered there, that's what you're going to get for the second dose. So if you're behind on inputting that reporting, that may impact how many doses you get. So you got to do that as soon as you can. The second doses will, not may, they will be delayed. It's going to be delayed up to, or well, I shouldn't say the delay is going to be up to 40 days, but the guidance is that, you know, from, and we're speaking specifically Moderna here, you can give it anywhere from 28 to day 42. Now, the interim clinical considerations for both of these vaccines, both the Pfizer and the Moderna, say that you can get the second shot up to day 42. So that means that, well, at least Dr. Gowner explained it, some of you guys might not be getting the second dose on like day 28. It may be day 34 or something like that. So you're going to have to be ready to go pretty quickly when you get that second dose. Those, in terms of second doses for those that discharge early, there's kind of 3 different buckets here. For those facilities that had the curative service, the residents must go to curative, to one of the 6 curative sites throughout the county to receive their second dose, unless curative is going to come back to your facility to do the clinic, and they can, and that resident can come back for that clinic date. Outside of that, they'll have to go to one of those curative clinic sites. For those that had LA Fire, you had an LA Fire strike team come to your facility, your resident must go to one of the county sites, or if the LA Fire Department is coming back to do a second clinic and the resident can make it back to the facility, they can come back to the facility in that case, but otherwise they're going to have to go to one of the county sites for second doses. For those facilities that did the vaccinations yourselves, the recommendation is to have them return once you get the second dose. For those with transportation issues, we've talked to a number of the health plans. I don't know that all of them offer transportation assistance, but I know that there's some of them that have a real interest in being able to connect their members with transportation to get them back to any of these locations for that second dose. And obviously they want their health plan members to be as healthy as possible, so they have an interest in making sure those folks get to the second dose. So as you discharge those folks when they go home, make sure that they have the ability to contact their health plan to get back somewhere if they don't have the ability to get transported. And there's still 33 buildings not signed up with CalVax, or you're in the very early stages. I sent an email to you guys, those facilities this morning. Expect a follow-up call on Monday if we don't see any activity that you signed up for COVID. This is, or for CalVax. It's super important. You're not going to be able to be a vaccine distributor without going through this CalVax process. Super important. So you got to do that before it gets too late. All right, and I will say that in terms of the vaccine, I don't know if you guys heard the update, but Blue Shield of California is going to take a leadership role in the distribution of vaccine from here on out. And what that means for us long-term, meaning, you know, the either new residents that didn't get a chance to be caught by one of the CVS or Walgreens clinics, or new resident that you didn't have vaccines for down in Los Angeles. We don't know what that means for supply. We've been pushing the state very hard to utilize the existing long-term care pharmacies and the you know, the resources that are within that community. It just seems like we have a mechanism for getting vaccines to you guys already built, but with this new kind of a coordination approach from the state, we don't know how that's going to play out. We don't know if the state is going to send the doses to individual providers, whether it's going to be retail pharmacies, whether it's going to be health systems, whether it's going to be hospitals, whether it'll be directly to us. Sadly, we had once been a little more confident about how this was going to continue to roll out. Now we're not quite so sure, and that uncertainty applies in Los Angeles as well. So we'll keep you guys posted on that. In the interim, we want to continue, doing these things that Los Angeles has asked us to do. And then if it changes, we'll pivot and we'll do whatever's next. But we're pushing them real hard to make sure that we have a long-term vaccination plan for both residents and staff. All right, I think that was all of our updates for today. Let me get, there we go. Yeah, I think that's all of our update for today. Let's get to questions. Let me pull up the question box here. Give me a sec. All right. Lots of questions. Okay. All right. First question, if no resident cases in the building and no other positive employees, can you assume an employee positive with COVID is community acquired and not work related in relation to the 300A form? I would absolutely say that's not an exposure from work. Now, tomorrow, if a bunch of people spike positive, symptoms, then that may be a different thing. But I think, you can pretty clearly say, we're testing folks in our buildings very frequently. We have a pretty good understanding of whether COVID's in our building pretty quickly. And so if you're not seeing other positive cases in either residents or employees, I would almost unequivocally say that is community acquired based on our ability to test and get a look inside of our facilities. I don't think that's a stretch. And I certainly would not put that on my 300A. I'm not an attorney though, so but that's my personal opinion. But I think an attorney would agree with that. And we had a similar discussion when the attorneys were on, and they both concurred that they would not record that on their 300A. Next question, aside from increased electricity charges, what type of costs would we be looking at for the actual air handling equipment? That's a great question. So those portable HEPA filtration devices can be anywhere from $180 to a couple $1,000, depending on the size and the number of air changes per hour they go through. I will say there are infection prevention and control requirements that revolve around the machine themselves, because those filters need to be changed. And when they do, you don't want fomites or the aerosolized fomites that are still contained within that filter to be resuspended in the air. So the people that clean that, sorry, I'm trying to minimize my screen here. The people that clean that need to wear full precautions. So they need a respirator, eye protection, a gown and gloves, definitely. So as well as it has to be obviously cleaned frequently. That's no different than the cleaning that you're doing for anything else that's a high touch surface. All right, and next question. I had read that facilities subject to the ATD standard didn't have to do this COVID prevention plan. Are SNFs not subject to the ATD standard, but only the respiratory protection program? So that's a great question. The ATD standard applies to us. And then what we are called is called referring employers. So under 5199, unless you have a facility that has negative pressure isolation rooms already set up, then you're probably a referring employer, which is 99% of the skilled nursing facilities. That means if you get an infectious airborne disease, forgive me, I'm gonna pause for a second. I apologize with these plans, guys. So when we're us as referring employers, that means that when we get an infectious disease, we don't have airborne isolation. So our responsibility is to transfer those folks out to a level of care that's appropriate for that airborne disease. And generally that's going to be to an acute hospital with the ability to do isolation. And now in coronavirus, we can't do that. We've basically been told that you have to hold those folks in place. And so with us, that means our model respiratory protection program has to dictate all of those folks that are taking care of those residents, and then in the spaces in which they take care of those residents. So that's where we're covered. That's our employees that fall under the respiratory protection program. Now, if you have, let's say, administrative staff that have no interface with residents, or you have medical billing that doesn't have any exposure to residents, then they would not be a part of your respiratory protection program, because you wouldn't fit test them and necessarily train them to wear a respirator at work, because they don't have occupational exposure. But if you have somebody that works in one of those areas that also takes shifts on the floor, that also helps out, and they have exposure risk, then you want those folks fit tested, and then they would not be included in this COVID prevention plan. The COVID prevention plan only applies to those folks that are not in your respiratory protection program. So you can do it one of two ways. You could have the COVID prevention plan and your mitigation plan. The folks in the mitigation plan are your people that are fit tested. The folks in the COVID prevention plan have no occupational exposure. Or you can write everybody into your mitigation plan and say everybody in the building has occupational exposure, and we're going to fit test everybody. That's your option, but you've got to write that into your respiratory protection program, that everybody in our facility is going to be fit tested. Now, that's a huge problem. So it may be easier for you to just say, we're going to have two things: a COVID prevention plan for those that don't have exposure, and for those that do have exposure, you're going to fall under a respiratory protection program, and we're not going to worry about the COVID prevention plan at all. Hopefully that explained it. I'm sorry this is so confusing. I wish it was easier. I really do. All right, next question. Oh, sorry, I scrolled down too far here. We have a resident who self-reported that she tested positive last month through drive-through testing location, but could not provide us a copy of the result. Without confirmation of a positive result, we placed the resident in a 14-day quarantine and included weekly surveillance testing. In cases like this, who do we call to verify the result for LA County residents? That's a great question. I don't know, but I'll reach out to LA County to see if their recommendation. I'm assuming they would concur with your decision to put those folks in quarantine for 14 days. But there's got to be a way that we can check this information, and I'll try to find that out to see if there's a way we can do that. It's possible that their health plan may have some of that information. I just don't know, but I'll find that information out, and we'll include it. Gosh, I think we can do it on next week's webinar. You know what? The person that asked that question, can you put your email address into the question box so I can send you a response before next webinar, the next webinar on Friday? If you can do that, that way I can give you the response and you don't have to wait a week to find the answer to that. So, all right. And Summer, can you do me a favor before I cut this thing off and lose her email address? Can you write that down for me, or at least capture that?
Of course, yeah, I have it recorded.
Okay, great, thanks very much. All right, guys, that's the last of the questions. So if you've got any more questions, feel free to send them my way. If not, I'll give you 12 minutes back of your day. I want to say thank you very much to all you guys out there. Hopefully you have a great weekend. Don't hesitate to reach out. Thank you, Summer and Jamie. Take care, guys. Have a great weekend. Thanks.